This is the second part of the digestive system. We left off with the stomach and looking at how the stomach is actually going to act as a big churn, but also contribute quite a bit of the secretions necessary for breaking down molecules and helping the chyme to move along through the system. So we had actually talked about the idea that there are three phases. There is the cephalic phase, where the stomach is knowing that it's about to receive the bolus, which is now going to be called the chyme, and it is the stomach phase that is going to churn and secrete more solutions that are necessary for nutrition. And then there's going to be the intestinal phase, where the pyloric region of the stomach, this pyloric sphincter, will actually relax and allow for the chyme to now enter into the intestines. So this is kind of where we left off. I want to make a note here to tell you all a couple of things that I think I might not have mentioned in the first lecture, which I did yesterday. But anyway, now this morning I was thinking about a couple of things. This pyloric sphincter gets its signals for when it's to relax and release the chyme into the small intestines from the hormones that are being secreted during this process. Sometimes in babies, the pyloric sphincter is immature, so it doesn't relax, it doesn't get the signals, it's not as coordinated as it is when the stomach matures. So in babies, that pyloric sphincter can be rather rigid and not getting the signals to relax, to empty the milk into the small intestines. And so this is why babies will often spit up. And they, that's just a normal thing that they do. And then they tend to outgrow that as soon as the pyloric sphincter becomes more coordinated and the nervous system is actually working more as it should. Another thing that I wanted to let you all know about are the salivary glands. I had mentioned the parotid, the sublingual, and the submandibular salivary glands. What I had wanted to mention to you about these parotid glands is that these are the glands that are attacked by the mumps virus. The mumps virus has special receptors that can be received on these parotid glands, and this is why the face will swell in a very particular way that shows, makes someone suspicious that someone may have the mumps virus. This is fairly rarely seen now because of immunizations. The measles, mumps, and rubella immunization that is given in the part of the pediatric protocol has really reduced our numbers of mumps outbreaks. But occasionally you will see mumps outbreaks. We've had a few in Virginia in the last few years. There was a couple of outbreaks at college campuses in Virginia, so young adults getting mumps who may have not they probably received the immunizations as children because they have to prove that before going on to schools, but they may have worn off, or they may not have mounted a good immune response when they did receive the immunizations, so they had these breakthrough cases. Mumps typically is going to have this disease, viral disease, is going to typically have an okay outcome. It's very low morbidity mortality rates, but every now and then mumps can actually, the virus itself can descend into the testicles of the male patients and can actually lead to infertility. So there is a mortality rate associated with it, and we can prevent it now with immunization, or enough immunization that provides herd immunity. So anyway, I wanted to mention that about the mumps virus, and then I also wanted to make sure that I mentioned this about the pyloric sphincter in newborns, and how sometimes this is going to require an emergency surgery in newborns to release the sphincter so that milk can get through. As we understand, in newborns and children are most at risk for dehydration, serious complications, and so it is important that when a newborn, is being cared for, that you're being very attentive of how many times the newborn urinates, how often they urinate, and how often they defecate, because really that's your sign that breast milk and or formula is getting through and that the infant is well hydrated. Okay, so we're going to move on to the intestinal phase now and take a look at that. So in the intestinal phase, the first part, and I like this video because this slide, because the stomach has been removed. So the J-shaped stomach that would be here, where my mouse is kind of going, has been removed. This is where the pyloric region of the stomach is attached to the first part of the small intestines. This first 8 to 12 inches of the small intestines is called the duodenum. It is also referred to as the duodenal region of the small intestines. It looks even anatomically quite different from the second part of the small intestines, which is called the jejunum. I do have these regions of the small intestines listed for you to make sure that you know those regions on your lab when you are doing your lab. But at this point, the chyme that had been in the stomach the pyloric sphincter has relaxed, and the chyme is now entering into this duodenum. When that actually happens and the duodenum is actually stretching, so the duodenum is stretching, it is going to actually cause the release of several different types of hormones. So what we're going to want to know about is cholecystokinin. This is called CCK, cholecystokinin, and it is going to also release GIP, which is gastric inhibitory peptide, and secretin. So all three of these hormones are going to be released from the duodenum, the small intestines, and what they're going to end up doing is suppressing gastric secretion and motility, because at this point the stomach should be kind of empty. The duodenum is stretching and receiving these actual hormones, and what we're going to see happen in response to these hormones is that the liver is going to end up releasing bile through these bile ducts, that the bile is actually moving into these ducts to be drained, and you can see the duct here, the bile duct here, into the duodenum, the first part of the small intestines. This duct, from the bile duct from the liver, is actually joined with the duct from the pancreas, the pancreatic duct, and there's a sphincter here that usually is closed. But once the duodenum gets stretched and those hormones are released, then this sphincter will relax and bile will enter into the small intestines here, and pancreatic juices will actually enter from the pancreas, the pancreatic secretions, and we're going to see what they do. Now, bile is necessary, and you would want to know that bile is necessary for the emulsification of fats and the absorption of fats. So bile serves a very important function that way. Again, it is released from the liver, and we know that bile, we maybe remember this from hematology, bile is the breakdown product of hemoglobin, heme, breaking down to biliverdin, bilirubin, until eventually bile, and now it's going to be used for the absorption of fats. So the liver is doing this for us. When the sphincter is closed between meals, when the duodenum is empty, the sphincter is closed, bile backs up because it's being secreted 24/7. But as it is backing up, that's okay, because it's backing up and it's actually being sent to this little storage compartment called the gallbladder. They've made the liver look a little bit opaque so that you could see that the gallbladder, it's really tucked up underneath this lobe of the liver. You really can usually only see this inferior portion of the gallbladder. But between meals, bile is being stored and concentrated in the gallbladder. So it is predominantly cholesterol in its components, and it's being concentrated, water's being removed, and then when the sphincter opens, contractions happen of the gallbladder and this duct, and it expels that concentrated version of that. So if it is too concentrated or there's too much of this, they can actually form crystals that we call gallstones. If gallstones block this common hepatic duct, if they're blocking this area, it's blocking up bile that should have been coming from the lobes of the liver, and this is a very serious situation. This is going to end up not only causing discomfort, pain, and that sort of thing, but it can actually damage the liver, and it can be a life-threatening situation. The cystic duct is the one that actually goes straight to the gallbladder. You can live without a gallbladder, and sometimes the gallbladders have to be removed, but if they're being removed, it's going to be important that that patient understand that they should reduce fats in their diets, because the bile, we want to reduce the bile production that is happening and being, released here. So, the diets do have to be, hopefully, are going to be addressed, and the patients are going to understand that they can live without a gallbladder, but definitely their diets may need to really be changing because of that. Some people, their gallbladders just really don't function very well, and so that's usually a hereditary component. So sometimes you'll see people needing their gallbladders removed in very young ages, in their teens and 20s, and if you look back, they had a family predisposition for that the gallbladders really weren't functioning very well. So this is, we're talking about the secretion called bile. It comes from the liver. It is natural, it is normal, it is needed for fat emulsification and absorption. And then when we think about this pancreatic duct, that also, the liver secretes over a liter of bile a day, and the pancreas secretes over a liter for itself a day into the GI system. These pancreatic juices that are being released include enzymes that break down proteins. They're called zymogens, and enzymes that also break down amylose, so break down other things too, but we predominantly think about the pancreatic enzymes as breaking down proteins. So again, if there is inflammation in this pancreatic region, then we're going to want to make sure if somebody has pancreatitis that they are decreasing the amount of proteins in their diet, because when proteins get added to the stomach, it stimulates this pancreas to work, and you don't want to put any extra burden on it. So you really explain that if someone's had pancreatitis or is having that as an acute illness, that their diets, it's going to be important to address that and what they're eating. So this sphincter is, on this slide, is called the hepatopancreatic sphincter, which kind of makes sense because hepatocytes means, hepatic means liver. Hepatocytes are liver cells. You've heard of hepatitis, that's inflammation of the liver. So if you ever hear hepatic, it means liver. And pancreatic obviously is referring to the pancreas. So it makes sense it's called that, but I think you don't usually hear it called that. You usually hear it called the sphincter of Oddi, O-D-D-I, the sphincter of Oddi. Now, again, it's usually closed unless this duodenum gets stretched because it's receiving chyme from the stomach, and then that is going to produce those secretin, CCK, and GIP, and they're going to cause this whole process to happen. The pancreas, when it's secreting its enzymes, it's actually in a solution called sodium bicarbonate. And sodium bicarbonate and water, and these protease enzymes. But what that does to the pH of the chyme is brings it immediately back up to 7. If we remember, the stomach chyme, the chyme that was in the stomach, has a pH as low as 1 on the pH scale. And the lining of the small intestines cannot tolerate that. So this sphincter needs to open quickly as soon as chyme comes in, because we've got to get that pH back up to 7. And sodium bicarbonate from the pancreas actually provides that for us. So these are again accessory structures, the liver and the pancreas, to the intestines, but absolutely necessary, and we cannot live without these two organs. So they're absolutely necessary to sort of help to complete this chemical digestion process. So now when we think about chyme entering into the small intestines now has everything's at the party, if you will. The salivary juices are there, the gastric secretions, of which there were quite a few, are there. The liver bile is there, the pancreatic juices are there, and now everything's there so that that chemical digestion can complete. Most chemical digestion is happening during the small intestines. And I'm going to go to the small intestines just so you can see how long they are, and we'll come back to this in a second. The small intestines are about 22 feet. So since everything in the duodenum, they've removed the liver and the pancreas here for you to see sort of what this would look like. Everything's at the party now. And this is very convoluted, twisted. So it gives time for that chemical digestion, which most of it's happening right here in the jejunum. Very long, convoluted tubule, right? Hollow tube, 22 feet of intestines, so that the chemical digestion can complete, and most absorption of nutrients is happening in the small intestines, and really a lot of water reabsorption is happening. Think about how much you have intentionally been drinking and eating. Then your salivary glands, your stomach, your liver, and your pancreas are all secreting into this lumen, and now much of that water has to be reclaimed. You can't let all of that go. So water reabsorption, nutrient absorption, predominantly occurring in the small intestines. And there are three sections of the small intestines: the duodenum, the jejunum, this upper part, and then the lower part is the ileum, all part of the small intestines. Now, again, there were some slides that I kind of went through, but I want to make sure I go back just to be sure that you all are understanding how important these accessory structures are: the liver, the gallbladder, and the pancreas, emptying their products through the sphincter of Oddi, or hepatopancreatic sphincter, into the duodenum, which is the first segment of the small intestines. Again, these slides give you a little bit of idea about the anatomy. The right lobe, you can see the left lobe smaller. You can live with part of your liver actually functioning, and liver transplants, when they do a liver transplant, they're not usually transplanting an entire liver. They're actually usually just doing a partial part of that. The liver's pretty good at regenerating as long as the damage is not too great. There are many things that can adversely affect the liver. The liver is a huge filter of blood, so it really plays a role in our immune response, and it also filters our blood, so it plays a role in removing toxins. There are some toxins that are predominantly removed from the liver, filtrating them. Alcohol is one of them. Alcohol is a toxin. There are some medications that we know can be concentrated in the liver, like ibuprofen and acetaminophen. So those are just over the counter, but then there are also prescribed medications that can act as toxins to the liver. So when some people are given certain antibiotics or certain treatments, they're going to have, occasionally they're going to have their blood drawn so that they can check the liver enzymes and make sure that the liver is not being too taxed. If it is being too taxed, they're going to have to back off because of the treatments, because the liver is vital to be functioning for your life. You have to have the liver functioning. So I think I mentioned hepatitis. Hepatitis means inflammation of the liver. There are lots of different things that can cause the liver to be inflamed. There are viruses, dozens of viruses that can do it. Autoimmune diseases can attack the liver. And so we understand that there's a lot of different things that can do that. So if somebody has hepatitis and the blood work is not definitive, the serology blood work is not definitive on what the cause is, Usually you can do blood work to find out if it's a virus causing it, because of the immune response, which I know you all would go back and look at. So you can do indirect serology testing to do that, but sometimes biopsies are required, and the biopsies would be necessary for autoimmune disease diagnosis, and or cirrhosis of the liver. Cirrhosis isn't always caused from alcohol abuse, but it is still the leading cause of cirrhosis of the liver. Again, it is not the only cause of cirrhosis of the liver, but it is one of the leading causes. Cirrhosis is hardening of the liver, and it stops functioning. If anybody's ever seen a liver on autopsy, or from a comparative species, maybe you have dissected, the liver is actually smooth, it should be smooth feeling kind of structure. People who have cirrhosis of the liver, it becomes incredibly hardened. So instead of feeling very soft and smooth, you can think of it as cirrhosis causes the liver to feel like if you filled up a sock with marbles as much as you could fill it up and felt the outside of it. That's what the liver would feel like with someone who has cirrhosis, just not functioning. And so it comes to a point where the patient is only going to survive if there is a liver transplant available. So this is the liver, different aspects, an inferior aspect and an anterior view of the liver. You can look at the microscopic anatomy of the liver and these ducts and how these cells, the hepatocytes, are actually secreting their products into these ducts. And, again, you can take a look at that. And we do know what bile is. We do know you can secrete as much as a liter of bile every day. And the gallbladder is storing and concentrating that between meals. And it does a very good job of doing that. You can see by a factor of 20. So when we think about these secretions, it's a yellow-greenish kind of fluid. Unfortunately, probably most of us have actually thrown up contents from our small intestines that have moved through the pyloric sphincter, through the stomach, up through the esophagus and out. This is a very, it's not pleasant, but anyway, these biles do emulsify fats and aid in their digestion. So definitely serving a very important role as far as digestion goes. Now, again, gross anatomy of the pancreas, we said it's going to secrete a liter or more, a liter and a half of pancreatic juices a day. They do end up having a lot of sodium bicarbonate, which raises that pH of the chyme back up to almost neutral immediately as soon as it's filled in. So the sphincter of Oddi is what releases to allow that to happen. It's also filled with enzymes, zymogens, that are going to help to break down proteins. So absolutely necessary. We know that the pancreas, we've already learned in the endocrine system that the pancreas secretes 2 hormones that act as endocrine hormones that are released into the bloodstream and are going to play a vital, predominant role in blood glucose homeostasis. So this gives a little bit of the histology of these pancreatic cells and how they are being released. And again, you can see the sphincter here and how it enters into the small intestines. So again, CCK, cholecystokinin from the duodenum, this is going to cause that contraction of the gallbladder and secretion of the pancreatic enzymes. It's going to cause the relaxation of that sphincter so that these can be added to the small intestines. Secretin is really important because of the bicarbonate from the pancreas. So secretin is that hormone that we associate with that. Gastrin from the stomach and the duodenum stimulate those contractions as well. So again, 3 different regions of the small intestines. By the time the liver and the pancreas have released their products into the duodenum, first part of the small intestines, everything's at the party now. So chemical digestion is really going to pick up and take place because we've had the mechanical digestion of the mouth, the stomach, and we are now able to really be breaking down those big molecules into smaller ones so that the most chemical digestion is happening in the small intestines, and the most absorption of nutrients are happening in the small intestines. As far as carbohydrates and proteins go, when they're being broken down to their monomer units, they're usually being absorbed from the lumens of these small intestines directly to the bloodstream. Fats are a little bit different. Fats are actually going to be absorbed, or are going to move into the lymph that's bathing the small intestines, and from, you know what lymph is, because we have the lymphatic system chapter, and from the lymph, that those fats will move through the lymphatic vessels and eventually make it to the bloodstream. So carbohydrates and proteins almost immediately move into the bloodstream to be carried around and used by our cells. Fats take a little bit of an alternate route through the lymphatic system, but almost all absorption is happening here in the small intestines, and chemical digestion as well, and the reclaiming of water. Very, very important. Okay, so if you look to see approximately how long these three regions of the small intestines are, the duodenum approximately 10 inches average, jejunum approximately 8 feet, and then the ileum approximately 12 feet in the lower abdomen. And this ileum ends this last 10 to 12 feet, ends at a junction with the large intestines. This first part of the large intestines is called the cecum, and this is referred to as the ileocecal junction. As soon as the solutions end up entering into this large intestines, we tend to think of this now as feces. Okay, there's still going to be reclaiming of nutrients and reclaiming of water in the large intestines, but that's what we think about that. Now, as far as the small intestines go, the inner membrane lining is filled with microvilli, and if we remember from our study of cell biology in AMP1, microvilli on the top surfaces of cells aid in absorption, rapid absorption, because even though there are lots and lots of feet, 22 plus feet of small intestines they may be, it's still, as it's moving through that lumen, we still need these microvilli to have a chance at absorbing these very small monomer units that have been broken down, molecules, so that they can be absorbed into the bloodstream. And you can see this just a little bit of how this looks. Again, the fats end up moving into the lymphatic vessels, but the carbs and the protein, monomers of carbs and proteins, so amino acids and then those monosaccharides and disaccharides, move into the bloodstream directly. Well, that's all right. So this is an electron micrograph where you can see those microvilli, which is kind of cool. Segmentation is continuing to happen. Peristaltic contractions moving things along in one direction, but segmentation is also happening where this is constantly contracting and moving. Someone should always have detectable bowel sounds. If someone is not having detectable bowel sounds, even if, 24/7, then it could mean that there's a blockage. So segmentation is always happening. Peristaltic contraction should also be happening, and we do understand that. So this is showing you a little diagram of peristaltic contractions happening, so things are moving in one direction. Again, I've explained to you about carbohydrates, and they're breaking down into these monomer and monosaccharides and disaccharides, and that they get broken down to small molecules that are absorbable, and then also proteins being broken down to basic amino acid or small particles enough that they can actually be sent straight into the bloodstream. Fat, again, emulsified by bile, and as it's emulsified, will move into the lymph, and from the lymph, it will move eventually through the lymphatic system, the vessels, until it gets back to the bloodstream. So these are all This is talking a little bit about these different monomers, these different nutrients that are being absorbed. A nutrient is actually anything that can aid in cell function or growth. So it includes vitamins and minerals. These are all nutrients if they aid in cell functioning and cell growth, and they need to be absorbed. Some vitamins get absorbed unchanged. They're absorbed unchanged, but some are going to absolutely be necessary to be absorbed with what they're called lipid-soluble vitamins. So you really have to have enough fat in your daily diet that you can absorb these. So if you don't have enough fat in your daily diet, you can certainly be deficient in these very important vitamins for nutrition. Some are water soluble, so they can be absorbed without a meal, if you will, but some you would have to have a meal. So if somebody's taking a multivitamin, they should definitely be taking it with a meal that includes fat, enough fats. And you can be fat deficient in your diet, which would make you deficient in some of these other vitamins. Water balance, so important. Thinking about how much this digestive tract receives in any given day, 9 liters. You can't lose that amount of water. You've got to get that back, right? So that absorption is happening in the small intestines, mostly in the small intestines, but also continuing to be reabsorbed in the large intestines. If the water is not being reabsorbed the way that it should, you're going to have diarrhea. If you are dehydrated and too much water is being reabsorbed in the intestinal tract, you're probably constipated. So again, you should know that, think about that concept and make it make sense to you, because it absolutely does make sense. If water is staying in the tube, it's going to flush everything out. If too much water is being reabsorbed, things are going to slow down in that tube, and there's going to be constipation. And so this is why sometimes when people have issues with constipation, one of the first things they should do is just increase their water intake, because that can really help. Okay. The large intestines. Now the small intestines have been removed and we can't see those. We see where the ileum, little part of the ileum is still present in this picture for us, but the ileum is that last section of the small intestines. But where the ileum meets the first part of the large intestines, or the colon, people refer to this as the colon, right? This is called the ileocecal junction, because the small intestines is the ileum, and the first part of the large intestines is the cecum, but you will need to label these structures. So the cecum is this first part, and this is where, as the solutions are coming into this part of the large intestines, the final process for digestion is going to occur here in the large intestines, or what we call the colon. So this feces will move up. This is why this is called the ascending colon. It then moves across. This is called the transverse colon. Then it will move, and it's a muscular tube, right? And then it will move down the descending colon to the sigmoid colon, which is kind of S-shaped here, the sigmoid colon, into the rectum, which is sometimes referred to as the rectal vault, and then will be anything that's non-digestible or whatever will be expelled, and that is called defecation, right? So let's take just the anatomy of the large intestines. Each of these segments of the large intestines, the colons, are called haustral units, or the haustrum is one haustral units. And this is a muscular tube, just like the rest of the GI tract was a muscular tube. And there are going to be these contractions that are happening here to move substances along, the feces along. There's still going to be reclaiming of water in the large intestines and reclaiming of nutrients and vitamins. So important. The last part of your digestive process, this colon, involves the main way that this is carrying out a vital part of your nutrition is through the bacteria bacteria that live here. And there's more than just bacteria. There are other microorganisms as well, but predominantly bacteria. Your colon is filled with microorganisms, and that's a good thing. Now, the balance of which ones are there also is very important. There needs to be healthy microorganisms, because if they're present in large amounts, then it means that they protect you from potential pathogens that could enter. If there's enough of your normal microbes, which is called normal flora, then it's going to keep you protected from potential pathogens, foodborne pathogens, and other pathogens that can cause disease. So the gut flora is so important. We're knowing that it's playing a role in your immunity, your protection, your immunity, your immune system function. It also, we know now that it plays a role even in your mental health and well-being. So we're finding out so much about the microorganisms that live in your gut, live in your colon. We said that when you eat and drink, your food is not sterile, is it? Your food and drink are not sterile. They're not even meant to be. There are natural microorganisms in the soil. Our food grows in the soil. It grows from trees. And, there are natural microorganisms that should be reestablishing in your colon. We also said, though, that when you eat and swallow something in the stomach, most of them will be taken out by the hydrochloric acid. So the numbers get greatly reduced because of the shock of that pH. But as that chyme moves into the small intestines and it's moving through the small intestines, the microbes are getting out of their shock, and they're now, by the time they reach the colon, they're a little bit happier. The pH came back up, they're happier, and now they're starting to divide. And they're colonizing this organ that we call the colon. And that's a good thing. That's a really, really good thing. So the way that most of the nutrition is happening here is through the microorganisms. They are finishing out the digestive process. Those microbes are making vitamins B and K for us, which are absolutely vital. The microbes are living and protecting us, and as they do, they actually do produce some of these microorganisms are known for giving off gases. But when we think about gas in the colon, this is called flatus. Flatulence is gas that is passed from the colon. The average person produces about 1/2 liter a day, but some people more than others. You are also getting this from swallowed air. You can get it from carbonated types of substances. But anyway, it also from the bacterial flora that are in your intestines. So these microbes, again, are necessary. They are producing, synthesizing vitamin B and K. This is helping with the absorption of electrolytes. So electrolyte absorption in the colon, water absorption in the colon, production of vitamin B and K in the colon to be absorbed into the system, and all of this is very vital to your health. So just making sure I haven't forgotten anything. I don't think I have. I do want to, you can see what are some typical transit times as far as absorption and motility goes from when you first ingest something. And again, contractions are happening all the time. Mass movements happen 1 to up to 3 times a day. Defecating more than 3 times a day, depending on the consistency of it, may be considered diarrhea. Some people don't have 1 bowel movement a day, they have less than that. But anyway, people tend to have what's considered to be kind of normal for them. And anyway, kind of know what's normal for them. I think we had the word defecation. We know that that means expelling the undigestible material from the GI tract. If you looked at a coronal section of the rectum and the anus, you can see the muscles that are involved with this. There is an internal sphincter and an external sphincter, both. And you typically by the age of around 2 to 4 years old, there is voluntary control of these sphincters, so voluntary control of defecation. When the rectum vault fills, this typically is going to send a stimulus that there is the urge to actually defecate. The blood vessels that nourish these tissues are called hemorrhoids. These are hemorrhoidal veins, and this is an area where the body, as far as the veins go, y'all know veins have valves. The valves ensure one-way flow of blood back for the right venous return. But this is an area of the body that's sort of susceptible to having these veins stretch out, and a lot of it has to do with just pressure from sitting. So some people have occupational hazards of having hemorrhoidal veins because they sit a long time. Truck drivers, in the truck seats a long time, and there's also like the bumping, and so it can really force blood to sort of pool in these veins in this region. This makes me want to move where I'm sitting. Sorry. So it can do that. Sometimes women, when they are in childbirth, in the labor part of childbirth, the head coming through the pelvic region here can actually also block some of these veins and cause blood to pool in these veins and stretch out just during the labor part, especially if the labor part, the pushing part, is really long, a long time. It takes a long time. So anyway, that's what hemorrhoidal veins are, and they can be treated. They can also they're permanently distended veins, but they can be treated, and sometimes they can even be if they're serious enough, they can be surgically treated as well. Okay, so I think that was kind of all that I was going to talk about with the anatomy of the digestive system. What I would like to talk about are there some disorders, and I have the disorders tables for you here, but there are some autoimmune diseases like Crohn's disease that can affect anywhere in the GI tract. Crohn's disease, a lot of times when you've heard of people with Crohn's disease, you know it affects their colon, their large intestines. But it can actually, it's an autoimmune disease that can affect anywhere from the lips, the mouth, the stomach, small intestines, and large intestines. Often we think about small and large intestines, but that's Crohn's disease. There's also something called irritable bowel disease, and that is limited to the colon, and sometimes just really limited to the sigmoid colon area. Again, the etiology is really not well known. We do know there's probably a genetic basis for many of these things, but etiology of irritable bowel not really well understood. So other things that you can see, diverticulitis. Diverticulitis means inflammation of diverticuli. Diverticuli are these little outpocketings of these muscle walls in the colon. So I was seeing if I could see. Well, this is just showing you the rectum. It doesn't show any other, but it does show the inner lumen. So an outpocketing of this of the lumen, and these little out pockets are called diverticuli. And if something like food material or fecal material gets caught in those outpocketings, it can irritate the lining, causing diverticulitis. And somebody with this, if those outpocketings rupture, then it would be releasing, substances into the peritoneum, and this can be a life-threatening event. So, diverticulosis is the disease. It can actually be painful, and it can, if the diverticulitis leads to rupturing of those little outpocketings, it can be life-threatening. Also, sometimes you hear about polyps. Polyps are growths. Sometimes polyps are benign. You can have polyps anywhere. You can have them in your nose, you can have them in your throat, you can have little outpocketing tissue growths almost anywhere. You can certainly have them in the colon. And, people who do have them, they're typically going to be, through colonoscopy, if they're discovered, they're going to be biopsied, and they're going to check that they are not cancerous. They're not all cancerous, but some can be. Colon cancer is one of those cancers that is easily treatable and has a good prognosis if it is caught early. And that's a big if. So the important thing about being proactive with your health is making sure that screenings happen when they should. And just recently, they have actually recommended that colon screenings be done like a decade earlier than they had before. It used to be that in your 50s, they wanted to start in the 50s, but now they're starting just colon screenings like every 10 years, unless there's a reason that you'd want to do them more frequently, like maybe you have a history in your family of colon cancer, then they would do them more frequently. But now they're recommending that start as early as 40 years old, just colon screenings. And if, again, family history or some sort of symptomology that a patient has, then they may recommend them more often. So this is our study of the digestive system, and thank you for your attention to this. The next chapter actually is nutrition, and you'll see that it's a lot of repeat from what we've had, but never a bad thing to do. So just reading through that chapter is always a good way to sort of augment what you have gotten from the rest, and I will have a lecture on that. So that will be the next one. See you then.